Our program, please come in and get your chair, your favorite chair. Some of the broccoli salad, it was really good. It's so good. Get something to drink. My name is Beth Feynman. I am a nurse practitioner from the Cleveland Clinic in Cleveland, Ohio, and it is my honor to be here today with this Medscape Oncology program. We will have an interactive program today. We have online audience, hello everybody at home, and we have an in-person audience as well, and we're going to be discussing CAR T-cell therapy for hematologic malignancies, and this will be an interactive discussion on nursing strategies. This program is supported by an independent educational grant from Johnson & Johnson, Bristol Myers Squibb, and Legend Biotech. We want you to use your own technology because you're going to be playing on your phones anyhow, right? So, and listening to us and playing on your phones. But when you're joining, please do so on your personal device. You can see this QR code on the screen. You can view the slides, access today's content, ask questions, and participate in polling. So if you have your phone handy, please take it to look at this QR code. If you need to log into a Wi-Fi network, because cellular does not work very well in this building, please access by Medscape Live and use the password Medscape. All in lowercase. So here's the title of our program with two very smart and sharp-looking people. Like, who picks these pictures? So I am the moderator, as I mentioned, Beth Feynman from the Cleveland Clinic in Ohio, and it's like my honor to be on the stage today with these astute panelists. We have Amy Goodrich from the Cindy Kimmel Comprehensive Cancer Center at Johns Hopkins, and Caitlin Murphy, who is the chief nurse practitioner in the section of lymphoma, so she's a smart cookie, and she's from the Farber in Boston, Massachusetts. We're going to start today with a polling question. We have 3 total polling questions, so you won't have polling question exhaustion, I hope. This is just to get to know our audience. What is your level of experience with CAR T-cell therapies? 1, I have never used CAR T-cell therapy. 2, I have limited experience. Or 3, I am very familiar. What do you think this graphic is? I'm trying to figure out, is that... Okay, so we have very familiar, limited, or I have never used CAR T. You're in the right place, so thank you for coming. Number 2, how often is CAR T therapy given at your site? 1, none, but we are in planning stages. 2, none, we refer. 3, rarely. 4, sometimes. 5, on the regular. And 6, not applicable. Because I manage breast cancer. We don't do CAR T-cell therapy in breast cancer.
Yeah. Right? Yeah. Yes.
But all are welcome here, right? Everybody's welcome here. Ooh, on a regular basis. So who of the 49% want to come up here and give the talk with us? Then I can sit in the audience and have more broccoli salad. So the agenda is as such. In this program, we will discuss the following. Welcome introductions, done. State of the disease, CAR T-cell therapies and hematologic malignancies. CAR T-cell therapy, we'll talk about the logistic and practical factors. Caitlin is going to demystify complexities of CAR T-cell therapy and adverse events. And then we are going to have our concluding remarks and audience question and answer. And again, if you scan that QR code at the beginning, you can interact by using questions on that. We have an iPad here that the questions come to me, and then we will review all of them that we can. So there's your QR code again, just in case you didn't have access to it. We'll leave that on for about 5 more seconds. And nobody's looking at it, so I'm going to change the slide. So the state of the disease, Amy Goodrich, you're up.
Thank you, Beth. Okay, so many of you are familiar with CAR T cell therapy, but this is a living drug. And for those of you who are not familiar with this, the T cells are pheresed from each individual patient. Their T cells are sent off to a manufacturing facility depending which agent the patient is receiving. The T cells are genetically modified for that specific patient and then reinfused back in, where Caitlin is going to talk to you about all the fireworks that happen once those supercharged T cells are reintroduced to a patient. So that is it in a nutshell. There is way more to it than that we could spend this whole time talking about, but we will not do that. So what is the state of CAR T cell therapy? So there are currently 7 agents approved in oncology, and you can see we've got 2 for myeloma, 4 for lymphomas, 1 for CLL, and 2 for ALL, and that equals more than 7, but there's some overlap there in those agents. And even though we have a growing number of agents available, this therapy is grossly underutilized, and I'm going to show you some really unfortunate data on how few patients are actually receiving CAR T therapy. So looking at 2017 to 2024, where is CAR T being used? So the majority of patients are lymphoma. That has the highest area of use. And myeloma is second. And in both of those diseases, the CAR T is being indicated earlier. Initially, it was, third, fourth, fifth line. And now we're going to show you by agent using these drugs earlier in treatment courses. Leukemias, acute leukemias, these are fewer patients. We are using it in those as well. And CLL, it's really sometimes challenging to find the optimal patient because these folks tend to be older with lots of health issues. But these are the populations we're using CAR T in. And you can see that between 2017 and 2024, there was a 50% increase in usage in lymphomas and a 30% increase usage in myeloma. That does not mean 50% of lymphoma patients and 30% of myeloma patients are getting CAR T. It just means that there has been more uptake in those diseases. So what are the targets that we are using at this point? So in our lymphomas and CLL and B-cell leukemias, CD19 is our target, and you can see the list of agents here that are utilized in those diseases with CD19 as the target. BCMA, which is overexpressed in myeloma, we've got 2 agents, and then anito-cel is an investigational drug that is coming in the BCMA targeted arena. And then there's a new target under investigation in myeloma, GPRC5D targeted CAR T, which is arlo-cel. So lots of things here and lots of things coming. So if we look at the approval timelines, we started out with axi-cel and tis-cel, and then we're coming, down the line, and we've got anito-cel and others. There's a whole list of things that are really under investigation. But I want to bring your eye to the red content here, where you can see initially axi-cel was third line in large B-cell lymphoma and then moved into second line. You can see the same for ita-cel in myeloma, liso-cel, both earlier lines and just relatively recently marginal zone lymphoma. It's approved for marginal zone lymphoma, so expanding the indications and earlier therapy indications, and same for cilta-cel. So, we're using more CAR T earlier, and patients are really doing better when we're not waiting until it's the last thing that they have on the option list. And then, I didn't say about the 3-year follow-up data. So, the older these studies get, the more mature these studies get, the more follow-up data we have on these.
And I just wanted to say one thing too about that, is that when you have lymphoma and myeloma, there's attrition that occurs. Patients don't get to that second or third line therapy from comorbid conditions. They decide they don't want to be treated. They go off and they move to Florida. And so I think that there's an opportunity now that it's earlier lined to get those early referrals, and we'll talk about that later,
yes,
for access. So that'll hopefully expand.
Yep. And then I am not going over all these trials, but if you can just put your eye on the efficacy percentages, and these trials are not all apples to apples. So the relapse refractory ALL for tis-cel is not the same as the CLL or the ALL relapse refractory for brexu-cel. These are not head-to-head comparisons by any means. But you can see these are very high efficacy rates for patients who have very few options or very few good options. So this is really an exciting therapy for all of these patients. Same for myeloma, and you can see here ide-cel, 2 or more prior lines of this therapy, cilta-cel, more than 1 prior line of therapy, and really good efficacy for those folks as well. So looking at the effectiveness in ALL, again, very high efficacy rates, remission rates, measurable residual disease negative in a high number of patients. Same for myeloma, high response rate, really good overall survival at 1 year of 87%, and then that 3-year updated of 76%, which is really exciting for those patients. Same for lymphomas, up to 80% response rates, and then there's a wide variety of progression-free survival at 1 year between 40 and 75%. And then CLL is the one area where we're still trying to struggle to figure out who the right candidates are. The folks who respond well do very well, but the folks who respond very deeply are not huge numbers of folks. So more to come with that. But Beth, you were talking about early referrals. So how would early referrals continue to improve outcomes?
Oh, absolutely. So if you think about it, and Caitlin's going to walk us through the process for those 51% of you that don't know as much about CAR T, it's a lengthy process from coming to the center to having the initial consult to discussing through shared decision-making the risks, benefits, and alternatives of that therapy, to then clearing it medically, and then actually harvesting your cells. And for a lot of these patients that are rapidly progressing with their myeloma or lymphoma or leukemias, you can't necessarily have that time to manufacture. So early referrals are critical. So if you're in the community or even in an academic center that does not do CAR T, it's really important to give your patients permission to seek that second opinion, even at diagnosis. It's not like really a second opinion because it's saying the first opinion was wrong, because it's not. It's just establishing that connection with that referral center so you can work together. Access to clinical trials is also there. But again, we're seeing in myeloma, there's a CARTITUDE 4 study, CARTITUDE-1 study that had heavily pretreated patients who had no other therapies. They got a single infusion of cilta-cel, and it was reported last year that after 5 years, there's a percentage of patients that have no evidence of disease. And so now in myeloma, we're talking about cure, and what is that definition of cure in myeloma? And so now that's heavily pretreated patients. Hopefully we'll get more patients early on that will be translated to cure. What about referrals for you, Caitlin? Do you see that as a barrier to?
Yeah, and I think the key point that you mentioned is that first diagnosis. And so there is that rapport and that relationship. And I think that leads to the opportunity that when they do relapse or have an early recurrence, we're pretty well suited to bring them in. We already have a trusting relationship, and we can move pretty effectively through what can be an arduous process with CAR T.
And then there is debate on outcomes from trials versus population, real-world studies. Caitlin, do you want to talk about that?
Yeah, I think the piece that when we can move these therapies earlier, patients aren't, they aren't as sick as they were when these therapies first came out 10 years ago plus. And we start to see that we're getting much better symptom control, much better disease response, and they're getting much more durability, and they aren't going to have to go through so many lines of therapy. And so they're a much better fit patient than I think what we understood from our the toxicity window with our earlier experiences.
Absolutely.
Yeah. Okay. So what's coming? So I talked about anito-cel in myeloma, which is a BCMA target. I talked about arlo-cel, which is GPRC5D. I don't do myeloma, so that's not coming off my tongue.
You did great.
Thank
it was
you.
perfect.
Thank you. And then there are more CD19 directed, and to me, this is very exciting, off the shelf. We need off-the-shelf products to take away all those trips for their pheresis, the expansion, the delays in therapy for these cells to be expanded and sent away to be expanded. So I really think off the shelf is going to change the game for a lot of patients, which is really exciting. So fingers crossed that those work. And then what are our treatment challenges? So this is kind of a complicated slide. We're going to start on the top of this slide, and there are about 150 CAR T centers in the United States. About 40 of them offer all of the products, but 44% of patients who are referred to CAR T centers never get CAR T. So they're probably being referred too late, or there's some ineligibility or something. So keep referring patients, but just know that just because you refer somebody in doesn't mean they're guaranteed they're getting CAR T. And then these bottom two are really dismal, that only 5% of patients with diffuse large B-cell lymphoma in a database review of 2,200 patients received CAR T. Myeloma is even worse, 2.6% in UC California database, 12,000 patients, only 2.6% of them got CAR T. So we really have a lot of work to do here. And then, a subset of these patients with documented eligibility had absolutely no recorded discussion about CAR T. So there are patients who really could benefit from this who are just not being directed to a CAR T center. And so let's talk about eligibility and availability. So some of the hot topics are, okay, so we know everybody knows about ICANS, or if you don't, you're going to know about ICANS. But Caitlin, what neurological history do you consider a contraindication for CAR T in light of the neurological toxicities?
Yeah, and I think this, there's been some more emerging data where we think about disease characteristics with CNS involvement, that I think we're finding more and more information to support that we can utilize these therapies really safely. I think when we think about seizure disorders and some of those components, we're really working really well with our neurology colleagues to find a way in which we can reduce any type of contraindication that we want to be able to use CAR T.
Yeah. Beth, do you have thoughts about that?
Now, so for our myeloma population, if you have a history of Parkinsonian symptoms in the family, or a personal history, or maybe for your livelihood, sometimes we would think again about offering certain types of CAR T-cell therapy, but it's still important to have a discussion. What we won't talk about today is the bispecific antibodies, which are off the shelf, and in many lymphoma and myeloma patients, these represent an opportunity where you can't wait for the manufacturing of these cells to then have an effective therapy. So those are the patients that we would offer that, but it's a very small number. Like, we do a lot of CAR T at my center, hundreds of CAR T for myeloma and lymphoma per year, and I think you just have to have a discussion. Let the patient decide what they want to do and involve them in the discussion and risks and benefits.
Yep. Caitlin, what's your favorite thing about CAR T therapy?
We were kind of discussing this together, and I do think that there's so many great benefits. I think the time of treatment and time on treatment, time in the clinic, and those kind of things, you buy a lot in the first beginning part, but I think when we have this 3-5 year follow-up data that is so durable, I think that we really can say with a lot of confidence that this can be a one-time shot that gives you really durable response and, as you mentioned, cure potentially.
Yep. And then Beth, for inpatient CAR T therapy, how long is a typical stay? And we know that the myeloma products are different from the lymphoma products.
Yeah, I wish we had a really pretty slide that looked at this. I don't know, maybe you have one in your deck with the I think you might have the CRS onset and ICANS. What's so nice about the myeloma products is that we give the majority at my institution outpatient. So they have this process where they harvest the cells and then it gets shipped off to be manufactured, and then it'll come back and they get lymphodepleting chemotherapy, and then they can get their cellular infusion all outpatient. And we know the onset of CRS for cilta-cel is on day 7 typically. so we have an admission on day 5. So you're shortening that hospital stay, and then hopefully they're out of the hospital within a couple of days after that CRS event. We talked before about possibly prophylactic tocilizumab, which I call Profitosi. And so I think in the future, we might have more studies to support prophylactic tocilizumab outpatient to shorten that hospital stay. What about lymphoma?
So
You don't do inpatient. I wasn't supposed to ask you anything about inpatient.
correct. I don't do inpatient, but it's really the same thing. We try to keep people out of the hospital and really just focus on those, those high-risk times. Caitlin, do you want to talk about steroids and CAR T therapy?
Yeah, I think we interpreted this question a little bit differently. So I think 2 ways that we can think about it, where we utilize bridging steroids as a therapeutic option to kind of control disease coming into it. And then we also think about steroid use for someone who has maybe a rheumatologic disorder, an autoimmune disorder that requires some low-dose prednisone. And so there is opportunity that we can manipulate that and still safely be able to utilize these therapies. So steroids aren't a contraindication.
Right, and they were early. We really thought that steroids needed to be avoided, and have learned that that really is not necessarily the case. And so now I'm going to hand it over to
You did such a great
Beth.
job. Great job on the
you,
first
Beth.
section. I'm going to move on to the second section. Thank you, Amy. And we're going to discuss CAR T-cell therapy with logistical and practical factors. Don't forget to scan your QR code if you didn't already do it. I know I'm a broken record, but I was told to say this again and again, because this is a model of learn, ask, discuss. So you're going to learn didactically from Caitlin, Amy, and I, but then you're going to hopefully ask questions so that we can all discuss together, and hopefully we'll have shared learnings. I always learn from my audience, right? So, and my presenters. So send us your questions. We already have a couple, which I'll integrate and call out during our next presentation, because I'll be talking about it in this presentation. So this is what I like to call the long and winding road of hematologic cancers. So what happens when you're diagnosed? Like, unfortunately, like a solid tumor, there's a stopping of therapy, there's a cure. We don't really have that in many of our blood cancers. And so it's a long and winding road that gets complicated by physical, financial, social, and geographic factors. And then also, especially for those that don't live near a treatment center that utilizes these new therapies, clinical trials, you have a lack of timely referral. More and more, we're encouraging referrals, and thank you for asking the question. I had one of my friends said, when you say early referral, are you indicating this is before the patient relapse or before becomes refractory? And most larger organizations are recommending a collaboration in care at diagnosis. So it's not saying that that community physician does not know what they're doing, because they're absolutely they absolutely do in many cases. There's standard regimens for lymphoma, there's standard regimens for myeloma, and it's okay if it's not at diagnosis. But now we're trialing CAR T-cell therapy at diagnosis. So instead of a stem cell transplant for myeloma, where you would do the induction of 4 drug therapies and then consolidate with a transplant, we have a very sophisticated far-along study that's randomizing patients to CAR T versus transplant. So you get that one cellular therapy and then no maintenance. And so how cool is that? Caitlin talked about the time off of therapy and giving that back to the patient, and that's really critical. So again, early referrals for any of these blood cancers, so you can collaborate in the care, is important, because patients should get their care in the community, in the home that they live, and not have to drive and pay for parking.
Yes, and those of you who treat lymphoma patients, and that's Caitlin and I, that's what we do, but you know those double or triple hits, or people with stage 4 disease, like, you know who the people who are at high risk for either being primary refractory or relapsing very quickly. You know who these people are out of the gate many times. Those are the ones
Get them to the Farber or Johns Hopkins.
that we need to be seeing, right? Not the one with stage 1 or 2 disease that you have a 90% chance of curing with R-CHOP. Not those, right? Because there's a lot of those out there with diffuse large B cell, but there are a lot who really do have very high risk disease who should be getting funneled in early.
Yeah, and we're going to discuss that in a moment as well, some of the general recommendations that have been created. The financial resources are a barrier, and we'll talk in a few minutes about some analysis of studies and how, the financial toxicity of cumulative treatments might prevent people from getting CAR T, but you might have a lower socioeconomic status because you are unemployed or you live in an area where you don't have a high income. There are travel and lodging assistance. So if you're sitting in the audience and you don't practice with occasions with CAR T, know that the manufacturers do oftentimes reimburse for travel and lodging. That's a perfect opportunity for clinical trial participation as well, because many of our pharmaceutical sponsored studies will, it's so cool. I have a study going on right now. They get 3 nights at a hotel stay at this Intercontinental Hotel. And they also get daily stipend, not only the patient, but the care partner, because you have to have a care partner or a caregiver in order to receive these therapies, and they want you to stay on site 3 days a week for 4 weeks. And so it's like a vacation, right? So know that there's support programs as well. We have foundations and local support through hospitals. Some of the larger universities have small grants available, but we have other resources such as patient advocacy groups, Cell Therapy 360 locator to find these sites, Susan Lang pre-CAR T-cell, so if you want to get a CAR T-cell opinion and you're not actually getting it right now, they have that travel assistance grant, so you can apply for a grant for travel assistance, and then Blood Cancer United, which was formerly Leukemia and Lymphoma Society. So there are some misconceptions about who's a candidate for CAR T-cell therapy. It varies according to your disease and stage. We want to make sure that you meet the FDA-approved label indication so that your insurance will pay for it, but age is not a restriction. And it used to be like, oh, the upper age of cutoff is 65 for transplant, and then we started cutting off for cell therapy. I have an 86-year-old who's extremely fit pickleball player, and they're getting a CAR T-cell therapy pretty soon. But we really try to have a good life expectancy of greater than 6 weeks. But if it's disease-related, some of our aggressive cancers, if we can manufacture them, it's really because of the manufacturing of the cells. We still want to be able to get them back. The adequate organ function, ability to tolerate lymphodepleting chemotherapy with fludarabine and cyclophosphamide, and then no active or serious infections. Those are just general contraindications. But most hospitals have review boards that if you have somebody you want to put through CAR T or stem cell transplant, they have a committee. Do you have something like that at your institution?
Yeah, I think especially with adequate organ function, I think from a cardiovascular standpoint that oftentimes is someone where we are fortunate to have cardio-oncology be a partner, and so we can really optimize cardiac, their ejection fraction, and really they do quite well.
Any relative contraindication that you see that we wouldn't have already talked about, Amy?
I think people with really inadequate kidney function, those are a little worrisome, in addition to the cardiac issues. But compared to bone marrow transplant, it's much looser, much looser. So like Caitlin's saying, we really try to optimize folks to get them to CAR T.
And one that I wanted to point out that we don't have on this list, but it's the care partner or caregiver support. And so a lot of patients we've been able to get through CAR T that don't have a caregiver or a care partner, and so that's really challenging, but we'll talk about some of the lifted restrictions as well for CAR T in a moment. So geographic limitations. This is kind of a sad slide, isn't it boring? It says courtesy of Beth Feynman. I did not make this slide. I would have made more color on it, obviously, but there are only 2 CAR T centers among these 4 states up there. Who knows what those states are? I don't. Over there.
Dakota.
Do you know the states?
Dakotas,
It's the Dakotas,
Wyoming.
Montana, Wyoming.
North Dakota and South Dakota, I'm all over that one, but Montana and Wyoming, I think, yeah. Are you smarter than a 5th grader? Did you ever see that?
Is anybody from those states?
Yeah, there, we got some.
Got it.
But the vast majority of states are located on the East Coast. We have quite a few on the West Coast, but mostly just on the East Coast. That's why your 3 speakers today are from the eastern part of this country, because this is what we do. The impact of distance to a CAR T-cell access in diffuse large B-cell lymphoma was looked at. Amy already described that there was a database review that looked at people who received CAR T-cell therapy. The probability of an eligible patient receiving a CAR is decreased by 6.2% for every 10 miles. So if you're even 10 miles away, nobody wants to get in the car to drive to your CAR T-cell center. You can see on the slide over here on the upper part of the slope, New Jersey, Maryland, Connecticut, New York, and California are the better access states in the blue. but then as you go down the scope, then you have lesser access. I'm in Ohio at Cleveland Clinic, and we have 3 centers in Ohio, in Columbus and Northern Ohio. So again, we still don't have a good representation in my state even. If the average distance is 171 miles, the likelihood you'll get a car is 3.8%. So distance is really a barrier, and so we need to figure out how to overcome those challenges. This is another slide with a lot of small font on it, but I'll tell you what it says because I put it together with them. The probability of getting CAR Ts decreased by 48% when there was no approved treatment center within 25 miles. What are these numbers on the top? You're more likely to get a CAR T if you're female. Why did you say, Amy, you think that is?
Well, because women get health care.
Because in men, it's more common in men than women, but more women get the CAR T.
Women buy into health care.
Yeah, so it's interesting why. If you have a metropolitan county, if your age at the 3rd line treatment is younger, but at the very bottom, if you're non-white and you have a low household income and you're employed, forget it, you're not gonna get a CAR T. It's so sad. Like, everybody should have access to these good life-saving treatments. The improved survival rates in diffuse large cell were listed here in a projected volume. The study looked at the cumulative number of life years gained by increasing access, and this was modeled from the ZUMA-1 study for diffuse large cell. If the CAR T increased by 6.6%, you would have 9.1% eligible patients that averaged 105 years of life gained. Like, so you would live a lot longer by 10 years if you actually had access to the CAR T. So again, this is that sad slide again that says I made it, but I didn't. There are 2 CAR T centers among these states, and the vast majority on the East Coast. What do you think some of the things we can do, Caitlin, to reduce these geographic barriers?
Yeah, I think that part of it is we're going to allude to the REMS criteria and things that are changing in that care dynamic. I also think that there's an opportunity for great partnership between referral centers and being in a regional way. Currently, I'm in Boston, and we have 7 surrounding states that will refer into us. And I think that it's really effective when we have a really great referral network, and trying to reduce as much of what the patient is required to travel for, and what we can utilize other resources, whether it's telemedicine or other components that we kind of go to the patient for some of these elements.
And one of the things is, like, it would be so great if we could imagine a world where you can get your pre-testing, your echo and EKG locally, get your PET or CT scans locally, do a bone marrow locally. Some of this is just consolidated at the CAR T treatment center now based on the bundling and the reimbursement. What are some of your suggestions for minimizing burden?
Right, so I think that probably most people in this room are not aware of all those support systems, the travel, the lodging, those. Just to make sure patients are aware that even if it is going to be a potential financial burden, they should still come to us. They should still come and hear about the therapy and the support available, and that can be a game changer for a lot of folks. They're not necessarily paying for every single thing out of pocket like they may assume that they are.
Absolutely. So for our role as nurses would be to try to identify the closest appropriate site early on in the treatment. So that's a great role for us to be able to say, okay, like this, Amy's down the street here, what's your phone number so I can call you? Yeah. And how do I refer a patient to you? So identifying and then helping the patient just by picking up the phone to navigate and establishing that network is important. It's also important to refer as early as appropriate. As Amy said, some of your patients have standard risk disease. They just do well for a long time with standard therapy, but there are some of those folks with higher risk disease that we really want to get them connected and collaborate on the care early on because of all of the changing treatment paradigms. We want to investigate financial support for travel expenses for our patients. We have a little handout that we pass out to people, and some of the patient care organizations, I know the International Myeloma Foundation for our myeloma patients has some good resources on their website. And so finally, consider if your site could begin CAR T-cell therapy if appropriate. Amy shared that only 150 sites give CAR T, and only 40 of them give all of the therapies. So how do we get more people up and running? And that was one of our next questions. What are the main limitations hospital centers face when wanting to become an approved site to provide CAR T-cell therapy services for the population? I think Caitlin can probably answer that question.
Yeah, and I'll go into a little bit more detail around CRS and some of the therapies, and the tocilizumab being a really important piece that needs to be on site for the patient's potential to have CRS. So some of those things are financial limitations from the institution that may be a challenge in that way.
Yeah.
Yeah.
But I would challenge all of you that if you have a lymphoma patient in your chair, or a myeloma, or a CLL, or an ALL, just say to them, has somebody talked to you about CAR T therapy? Right? Because honestly, they should be, if no one's talked to them, they should be going back and asking their oncologist about it. And there really are a lot of resources, and we work very hard to make this accessible to everybody. But all of you, you have the patients as a captive audience. So there's no reason you can't say, hey, have you thought about CAR T?
Yeah.
Right? Why not?
And I can appreciate that there's so many therapeutic options that it's a hard landscape to navigate. And so I think that's where nurses can be an incredibly great advocate to
We're
say,
the glue that holds
Yep.
the people together.
Exactly.
I had another great question I want to share that's relevant to this section. How do you propose centers navigate insurance barriers, such as companies declining the closest center to the patient out of network? I had somebody, they had to go to Mayo Clinic Jacksonville, and they live like right across the street from our hospital. And you know what? I'm like, it's Jacksonville. We're in Cleveland. Just go. And they help to pay for it. But you don't want to upend your life for that reason. So we do a lot of appeals. I know we're talking a lot about AI here at this conference, and I think we need to embrace that. There's a free computer program called Open Evidence that I use to generate a lot of my appeal letters. Helio is also here as well, and that's another AI-generated engine. So if you're walking around, look at the Helio people, and that also can help you with similar insurance. And they pull from peer-reviewed resources like PubMed, NCCN, and the national guidelines. So if you're a busy nurse in your clinic and your doctor says, write me an appeal letter, then try to think about using that technology. And so we've actually been successful in a limited number of cases, but not all. So I think we talked about that. I'm part of a committee. A couple of years ago, Peter Idell, who's from Chicago, he was by where you used to be in Chicago, and David Porter, they're bigwigs in the transplant and cellular therapy division. They put together a panel discussion partnering with ACCC, the Association of Cancer Care Centers. I always have to think, it used to be a different name, Association of Community Cancer Centers. Yeah. I'm sorry, ACCC. I have a bag that has your name on it. I still don't know what it means, but anyhow, they put together some general recommendations, and the RECUR is the framework. That's the acronym for when you should refer diffuse large cell and other types of lymphoma. So they settled on, if they recur, then refer, because just as we had the discussion, we know that many patients can do well for a long time. Keep them in the community, don't burden them with the transfer. But if you do refer, they do have greater ability to organize resources, including financial, optimize their comorbidities, like, you know, if you go to the Dana-Farber, then you can have your cardio-oncology and a team approach to care. And then beginning the CAR T-cell conversations early. Just as Amy mentioned, if you're a nurse in the clinic and you have a lymphoma, myeloma, leukemia patient, talk to them about whether or not people have asked you or talked about CAR T-cell therapy, and encourage support group participation. We're now convened a panel that's looking at myeloma-specific guidelines, and then hopefully we'll move on to leukemia guidelines. But for psychosocial, there's also some barriers to CAR T-cell therapy, and what do those look like? Caregivers and care partners. Those are you don't necessarily have a caregiver or care partner, so sometimes we have to identify formal or informal. We have to make sure they have tools at home. If you're doing CAR T-cell therapy, whether it's inpatient or outpatient, we still expect some types of home monitoring, thermometer, pulse oximetry, and I think that's where the hospital systems can sometimes help out, and sometimes the insurances will reimburse for those types of things. Support network is super important, because especially the younger age individuals that need to go through this process might be working, they might be the breadwinner, so how can you help manage their resources? And then again, communication tools, when and how to notify the team of adverse events. What other kind of barriers can any of you think about that might not be listed here?
I think with the support network, when we think about the younger adult population and where we are moving these therapies earlier in line, I think that we think about our sandwich generation where they're caring for young families and their parents. So I think there's so many layers within that support network that are key to pay attention to.
So managing eligibility, this is, again, we're just going to discuss this together, but how do you keep your patient in optimal condition? A plant-based diet, high fiber, I think. Try not to, we were just talking about not eating fried foods. It's probably not a good thing to eat fried foods, but if you want a piece of pizza, you can have it, or some fried chicken, you can have it. We're in Texas, they eat a lot of barbecue here too, that's fine. But trying to do a healthy lifestyle, healthy living, encourage them. And I have this discussion with my patients. I don't want you dying of heart disease because you didn't go to see your primary care provider or be on the appropriate antihypertensive medication. Have them collaborate with a primary care provider throughout. We want to also make sure to could disease control. If we know you're going to get a CAR T-cell therapy while their cells are being manufactured, because they're not all off the shelf, like Amy discussed, in a perfect world, we could give them AlloCAR product off the shelf, but making sure that they keep good disease control. What are some of the bendamustine considerations you have with your lymphoma patients?
So bendamustine is a very myelosuppressive drug, and we would typically try to avoid using bendamustine before CAR T. Both from a collection perspective, it does suppress T cells, so that collection and expansion can be hindered, and then if we try not to give it between collection and CAR T because it is so myelosuppressive. It's very myelosuppressive.
Yeah, absolutely.
And really, it's the follicular lymphoma space where bendamustine is most used, and now there are so many other options that it's really not a strife to avoid bendamustine, but that's definitely something that we avoid.
Yeah, in myeloma, it's what worked before and don't give what didn't work. And oftentimes we're using a drug called talquetamab, which is a GPRC5D bispecific antibody after we get their cells out. We think in myeloma, if you have more effective disease control before they go into the CAR T-cell therapy, then it can minimize or lessen the risk of severe adverse events afterwards and hopefully optimize outcomes. So just making sure that your patient's getting something in between, especially if you did a community referral and then they send them back to wait for the manufacturing 4, 6, however weeks to wait, that the disease is not getting out of control. So if your patient's sitting there and not on anything, are you supposed to be taking something? It might not be your role, but it's something to be aware of, especially if they come in for a supportive therapy like IVIG. Patient identification and eligibility is also very important. We talked about the lack of referrals, and we'll talk more about this later on. And then the wait times can impact patient mortality. In the early days for CAR T, we used to have wait lists because there was a lack of available slots, especially for myeloma. Now, fortunately, there's no wait lists anymore. You can probably get an apheresis slot pretty quickly in most institutions, because as we saw, there's a dismal amount of patients that are actually getting CAR T-cell therapy. There are some REMS changes. In June of 2025, the FDA removed the REMS requirements for CAR T-cell therapies for those that were getting BCMA and CD19 CARs. We have reduced the driving restrictions to 2 weeks. So think about the burden of what was on the patients before. 4 weeks was the prior. And then, oh no, it was 8 weeks for a while.
It was 8
weeks for a while. I totally forgot about that. But definitely going down to 2 weeks is a real improvement. And then hopefully will translate to a potential for increased access if people don't have caregivers or care partners to drive them. And these are the CAR T-cell therapies affected listed on the slide. So we have some questions here. We got a ton of questions on the iPad, though. I would almost rather go to these, because I think some of them are in here anyhow. I was scanning them. When do we refer a patient to start getting resources? And so I think that's a great question, and I can answer that unless you guys want to answer that question.
Right. Well, when you refer them in and we start thinking about CAR T, and I'm assuming your institutions have a machine for CAR T, and there's a team and an onboarding team and a insurance clearance team and social work and the whole 9 yards. And that's really when that starts, is when the person on paper is a viable candidate, not not after they've screened and had all that done, but when we're really moving somebody toward CAR T.
Yeah, I think the travel grants, like let's say you live in the middle of nowhere and you want to travel from one of those 4 states that don't have any CAR T to like Utah or Fred Hutch in Seattle because you live over there, then you can get travel grants to help support that, and that's immediately too. I feel like I'm picking on those states. I'm not. I love the U.S., and so I'm not picking on those states. But I just feel sad because there's just such a lack of access in that part of the country. The other question I want to talk about, so immediately they can get resources once you start referring, and then how do state laws such as provider licensing affect access to these therapies? Can patients in a different state have a video consultation and work out without having to travel as an institution? That's a great question. Who wants to talk about that one?
Well, in my world, you have to be licensed in the state where the patient is, right? So, and all of those COVID era agreements have expired. Mm-hmm. So that's a tough one. Mm-hmm. That's logistically a tough one unless the provider is licensed in the state where the patient is.
Yeah. So it's also institution specific. What is your thought? And I'll share my thought.
Yeah, so we have, as part of our lymphoma program, many of our physicians have multiple state licensure maintained. We have a clinic in New Hampshire, so that naturally lends ourselves, but we have patients who are in Maine and Connecticut, Florida, but we do our best to kind of have that be a reduction in that barrier.
Yeah. So in my world, there's a difference between a new patient consult and a CAR T consult. So if you have a myeloma diagnosis and you wanted to get an opinion regarding your care, that's separate from the actual official CAR T cell consult. So we do go across state lines because we're not prescribing. We're just discussing with the patient. So we do video services there. Now, if you wanted to come to our state, we wouldn't be able to do as much video or telehealth if you're actually getting that CAR T. But again, it's very institution specific and state specific towards what you can do and what you can't do. Are there transplant programs that are not willing to bring in CAR T as an offering? And what are the CAR T services for that population? So I think the question refers to just 40 centers that don't have all the products. What do you think would be the barriers to not carry all the CAR T cell products?
That doesn't make any sense to me, that everybody wouldn't have, because once you have the infrastructure in place, you can really do any of them. I don't know if it's reimbursement, like, because state by state insurance is different. Mm-hmm. Maybe you're in a state where they,
and some cars
the preferred agent is something, is very consistent, and then maybe you just don't have to have all of them.
Yeah, you have to be accredited center, and so in my myeloma world, we have ide-cel and cilta-cel that are both approved, but ide-cel is not given at all institutions, and cilta-cel is not given. So they decided to put on certain drugs on formulary, and that's how that had occurred. Are there transplant, oh, we did that one. What are the main limitations hospital centers face when wanting to become approved to provide CAR T services? I think that was a different way of asking it. How long after CAR T are you requiring patients to remain near the facility? Ours is a month.
Yeah, it is. It's a couple weeks to a month, and it's very patient specific, based on what we give people a range so that they are prepared to stay for at least 8 weeks. But if they can slide out early, that's just a bonus.
Yeah. Exactly. So we're going to look at more of these in just a second. I don't know that we need to cover all of these questions, but these were actually brought in early ahead of time. Let's talk about outpatient CAR T, and what does that look like for you? Amy, do you want to start?
Right. So I think that we're all trying to move to outpatient CAR T, right? Everyone is trying to move to this because this, I think, will be the key to moving this into the community when we don't have to have inpatient admissions automatically. And I think that goes hand in hand with prophylactic tocilizumab, that if we can make this safer, we have all sorts of guidelines now. When we first started doing CAR T, we had nothing. So now we have nice guidelines for how to manage these patients. We are going to perfect the outpatient management, and eventually have guidelines, and hopefully by that time we have off-the-shelf products and prophylactic tocilizumab, and then everybody can do CAR T, or way more people can do CAR T than they are now. So outpatient is definitely the wave of the future.
So I did have another question about prophylactic tocilizumab. Are we worried that that will impede the efficacy of the CAR T cell expansion? What kind of studies have been done? Do you know anything about that, Caitlin?
There's some preliminary data that's supporting the use of prophylactic TOCI, and I think that that's been a major concern for all of us in terms of the efficacy, that you balance these things in terms of, we've seen how durable, we're skeptics in terms of we don't want to lose that durability and efficacy, but the benefit of having that prophylactic TOCI hasn't impacted efficacy in some of these preliminary studies.
Caitlin, if your patient doesn't get CRS or ICANS, does that mean it didn't work?
No, definitely not. It's a great question. It happens, you know.
And I think we're going to talk about vaccinations later on, so we won't talk about that here. And then, do you give prophylactic anti-seizure medicine? We do in the first month. I'm going to do one more question here, and then we have to go to the next slide. Please discuss, we're going to do that one later on. That's a long one. Do you run into issues with reimbursement if you do use prophylactic tocilizumab? So we do for bispecific antibodies in myeloma. It is in the NCCN guidelines, which really dictate whether or not we can give certain drugs. And so we don't have problems in our myeloma patients with a BCMA-directed bispecific antibody, but we do not give prophylactic TOCI for CAR T in my institution routinely. Maybe that's different for you, and do you have reimbursement problems?
We aren't using prophylactic TOCI for
We would love to, but the reimbursement is the...
Yeah. So until it's got enough weighted evidence so that it ends up in these NCCN guidelines, then we're not going to be able to, I think. We're going to talk about neurotoxicity screening in the next section, so we're going to hold on that question. What point are you using growth factor after CAR T cell therapy? So for our patients that have cytopenias, some of them get really neutropenic. We'll put them on levofloxacin or moxifloxacin prophylaxis, maybe some Flagyl, and we do periodic growth factors in my myeloma patients. They're less cytopenic, they're less heavily pretreated, so we're not seeing the distinct, terrible cytopenias as much. Amy's not giving bendamustine ahead of time, so she's not seeing as many cytopenias probably.
But it's really the same, and I feel like the earlier we're using it, the less cytopenias we're seeing, but we definitely do use growth factor if patients need it.
Do you remember the early days of CAR T? We were just like so afraid of everything. And now it's like, everybody get a CAR T, increase access. And now it's like so nice though. Isn't it great that we've continued to learn from our experiences, learning from the science and the brave patients that participated in these clinical trials, so we really know what's going on. So have you seen someone receive 2 different CAR T products? I have. And so what we try to encourage at my center is we have lots of CAR Ts that are off the shelf in clinical development for myeloma and lymphoma, and then we'll try to encourage them to go to a CAR T that's a clinical study, so then if it doesn't work, then we can go to the standard of care approach that we charge insurance for.
Right, but in the lymphoma world, we only have one target, right? CD19. So you would never repeat a CD19, but in the myeloma world, it's 2 targets. So even if you don't have clinical trials, the myeloma world, they can get 2. Eventually, lymphoma will have more than 1 target, but we're not there yet.
So we have this Arlocell, which is a GPRC5D CAR T in clinical trial, and so that's why we're telling our patients, go to this target and before the next one. And so also there's a theory about if you had a CAR T 4 years ago for myeloma and it lasted 4 years, just like a transplant, getting a second transplant in some hematologic cancers, that's something that you can consider if the insurance would reimburse it. We have lots of questions that we'll go through Caitlin's section, and then we can just do them at the end, I think.
Excellent. So we're going to talk a little bit about some of the complexities that happen in some of the adverse events now that we have a patient getting CAR T. They've made it to our centers. So always ask us the questions. So the big thing that we are going to talk about today is CRS, neurotoxicity, and then some of the delayed adverse effects and infectious potential because of these therapeutic agents. So which side effect consideration are you most concerned with around CAR T cell therapy? Is it cytokine release syndrome, long-term effects, administration of tocilizumab, neurotoxicity, or prophylactic medications.
This is so calming, that music.
All right, so still CRS is one of the top concerns, neurotoxicity and long-term effects. So not so much the concern
Look at the
around
prophylactic
tocilizumab.
zero. Nobody cares about the
No
prophylactic
one cares about
medications.
prophylaxis. We've got prophylaxis covered. We're
Hey,
we're
infections
nurses.
easy
Infections are easy at this point. All right. So specifically looking at cytokine release syndrome, we're thinking about this inflammatory syndrome with T cell activation. And I really like this graphic as it kind of alludes to all of the systems that can be impacted. Most often occurs with treatment initiation and leads to this massive release of inflammatory cytokines. We've seen their ferritin, their IL-6, their CRP markers all rising. And in relation, we can see initially a fever that 100.4 or greater. And then as we move through the intensity, we're going to start seeing some of the hypotension and then hypoxia as we move through the higher grades. And I think on the right side, what you can see is some of the organ impact because of all of those inflammatory conditions, where we're starting to see how that impacts and how it presents as the hypotension and hypoxia. So when we think about our agents in multiple myeloma, any rate of CRS, you can see across them relatively high rates. When we get into those higher grades, much more worrisome, a little bit more challenging to manage, really, really low rates. So I think that there instills a little bit of confidence in the ability for us to manage these really effectively and safely. When we think about lymphoma, there's a little bit of variability. I think when we're drilling down into the indication and the type of lymphoma that these are being utilized, and I think that there's some disease characteristics that we think about with the rate of CRS. But once again, you can see that those higher grade of CRS are really low. And then subsequently, the same is true for our leukemia population. So this is another graphic, I think, when we think about grading in CRS. So as we move through low grade, most patients will have that fever, will have a very predictable timeline based on the product, based on the indication. And then as we move through and see potentially some hypotension requiring vasopressors, we move into the intensity. And so I think when we think about who's optimal for some of these outpatient therapies, when we can see that they're grade 1 and grade 2, where we can really manage them quite effectively in the ambulatory setting, where they aren't requiring near ICU incidents of support, I think that this is instilling a lot more confidence in our ambulatory settings. So how do we manage these patients? So when it's grade 1, we think about observing them. That early fever, though, is a little bit worrisome in terms of the timeline. Does it happen really quickly? That gives us a little bit more of a flag that we really do need to consider that early tocilizumab. As we move into the grade 2, we definitely want to start thinking about administering that toci at that 8 milligram per kilo, and no more than 3 doses. So when we think about these patients who are not responding or they're moving higher into that grade, then we start thinking we need to incorporate dexamethasone or even high-dose methylpred. So for the most part, when we think about it, most of our patients lower grade, we can manage really well with the tocilizumab. But there is the consideration that we integrate the dexamethasone as they increase in the grade. And I think from earlier in our conversations around dexamethasone, where we thought there was a lot of concern around T cell expansion and the efficacy, I think what we've come to find out that the efficacy isn't impacted, that we really want to keep them at that low grade, low inflammatory state. And so we're integrating dexamethasone much earlier with a lot more confidence. And I think one piece that I do want to highlight on this is that when we think about CRS and we think about fever, these are hematologic patients. These are cytopenias. We're always thinking about, is there some infectious component of that? So that's always on our differential. But when we think about early onset or in the timeline of when they present with that fever, we're thinking about infection as well. So when we go into neurotoxicity, when we think about ICANS, it can be really subtle, and this is where it's really helpful to have a partner with your caregiver where they can start having maybe some language changes. We will have our patients write and sign their name, and so sometimes you can see a significant change in their handwriting. They may be much more sleepy or fatigued, and we understand that there's going to be some component of fatigue from the lymphodepletion, but this is a pretty different characteristic. And then tremor and seizure, we've definitely seen that as we've utilized these therapies and see a little bit of agitation. So I think being aware of where they are at baseline and then constantly reassessing throughout their therapy.
I have a question, Caitlin.
Yes.
Do you have any thoughts for alternatives to handwriting for ICANS monitoring if the patient can't write, or is there an eligibility requirement, like with the ICE score?
That's a great question in terms of, I wonder if there's some things that we think about, like hand tracing and certain like motor skills that I think would probably be a collateral that you could use as a similar one.
I will say that I have never encountered that as an issue, but there would obviously, if they don't have hands or like, you know, if they're missing limbs, I think just as you said, the motor part of it is what we're concerned about. And so how can we assess the motor? Maybe ataxia and gait changes would be something that I would look for. Sorry to interject.
No, that's
I'm
a
trying to
great
pepper in
question.
these
That is a
questions
good
as they're
question.
relevant. And there was another one real quick. Is there a protocol for testing ICANS smoothly if a patient cannot write? That was a second question. Isn't that crazy? And then the final one that was also on the ICANS realm was, when do you stop testing for neurotoxicity after CAR T?
Yeah, I mean, we still ask these questions. I'll see them in the ambulatory setting around day 14, and I'm still asking them, you know, can you take your left hand to your right ear? What time is it? Where are you? And so there's still an opportunity for a little bit of delayed neurotoxicity. It's a very, very small percentage, but we still
We're
are
usually
asking.
2 weeks is when we think that they're pretty cleared. So it's really about 2 weeks.
Yep. Excellent. So just looking similarly, when we think about CRS, we're thinking about rates of neurotoxicity, and I think this is inspiring in that the grades of any neurotoxicity is relatively low, but I think to focus in on the product that you're administering is incredibly important. So you can see a little bit of variability in terms of the rate and subsequently those high grades. And then similarly, where we're thinking about scoring, there's always a nice algorithm for this where you can ask questions and assess. And so when we're thinking about fully intact, that there's no deficits, you're looking for that prime time 10. And then as you can see or assess, they may be missing one of their components of orientation, they may be changing in speech or cognition. That's when we start to think we're moving through, and then this is really when we're starting to think about integration of dexamethasone to help support and reduce the grade. So here are some of those questions in terms of orientation, naming things, following commands, writing, and attention. So the counting backwards is often a constant question. You're going to ask me again. I know how to count backwards, but they become very proficient at the questions by the time they see you on day 14. So we're going to switch gears a little bit in terms of infection prophylaxis, and these are some of the, definitely during the initial presentation with fever that we have to rule out an infection, but when we think about prophylaxis as we are re-engineering, we're depleting their B cells, we're kind of changing the way in which their immune system functions, and so how can we effectively reduce the risk of infections? So we do a lot of prophylaxis in terms of HSV and BZV prophylaxis. We're constantly looking at IgG levels, and we really reconsider, do we have to add additional agents, antifungals, when they do become profoundly neutropenic? There's a lot of discussion around timing of vaccinations, and so we'll kind of discuss that, I think, all together, but also reevaluating, looking at hepatitis as a consideration, especially when they're having CD20 antibodies as part of their historical exposure. So thinking about what could these potentials be, and then these patients will require prophylaxis for 6 months and maybe even beyond because of that re-engineering of their T cells. And so we often will keep them on PJP and BZV prophylaxis for at least 6 months when their CD4 count comes above 200. With some high-risk patients, we'll keep it longer. Yes, Beth?
Hi. So 2 things about the myeloma patients that are a little bit different. Number 1 is everybody gets IVIG at the beginning, regardless of the IgG level, because they might have an IgG type of a myeloma, so it'll look like it's a high level, but it's actually, they have the functional hypogammaglobulinemia. That level does drop within a month usually, so we want to protect them against infection. The IgG infusions or sub-Q IG will go for at least 6 months, and then when they get immune reconstitution, we can do it less often. The other point that I wanted to mention about the myeloma patients is that sometimes because it's a BCMA target that's expressed on the plasma cells, they have this like prolonged where their CD4 count wants to say like 150 and it's like been like 2 years. And so how long do you keep people on TMP sulfa for prophylaxis of PJP when it's not coming up? I feel like the risk of infection in their immunocompromised state is like really high, and so we'll keep them on it until the CD4 count goes over 200, which sometimes it doesn't for like over a year and a half in myeloma.
Yeah. And I think there's a lot of conversation around how do we effectively administer IVIG in terms of, this is another, patients come to these big centers, do they have to stay for a lot of these supportive things? We really try to effectively manage these things local with infusion centers or with some of our immunologists so that we can get sub-Q IVIG and replacement there. So I do want to talk a little bit about the vaccines in terms of routine vaccination after CAR T. In the lymphoma space, we don't routinely do childhood immunizations again. We will oftentimes just do seasonal vaccines with COVID and flu, and if they haven't had shingles vaccination, then we would recommend those components, but usually not for a little while so that they actually can engage and mount a response to their vaccines.
Caitlin, go ahead.
And then I was going to say, if someone is getting IV IgG or subcutaneous IgG, they're getting immunity to those childhood illnesses through their IgG products, and so they don't need them. Even if you are at a place that gives those childhood vaccinations over again, they don't, because they'll be getting them through their IgG product.
Right, and then there was a question, if a patient refuses the post-CAR T-cell vaccines, does that mean they can't get a CAR T-cell infusion? And so we've had patients that have said, oh, I'll get this one, but I don't want to get that one. And you know what, I tell them, I want you to like not die of infection after your myeloma CAR T is supposed to be a potential long-term solution. And so we have that discussion. I can't make anybody do things that they don't want to, and it's not a clinical trial, it's not a mandatory recommendation, it's just a strong recommendation, and I have them see an infectious disease specialist.
Agree, totally agree, because there really are people who don't want to get vaccinations, and what I think is ironic, they're getting a genetically modified T-cell product, right?
But they don't want to get a COVID vaccine.
It's like 2 and 2 is only 3, but it happens.
Yes, and I will also say I have some patients who will say after 3 months of being on trimethoprim, I don't want to take anything anymore, and it becomes that conversation how beneficial it is to be on this prophylaxis and to maintain these supportive medications. All right, so when we think about delayed toxicities, we think about those prolonged cytopenias. There are patients that are really heavily pre-treated. They've had really significant bone marrow dysplasia because of all of these therapies, and so they are the people that are going to need some type of growth factor, or they take much longer to recover. We talked a lot about hypogammaglobulinemia and how we support patients through that, coagulopathies, infectious risks in terms of how the prolonged cytopenias play into those things, but we can see some late bacterial infections. This is also a patient population, they get every single upper respiratory infection. They're getting every course of rhinovirus, so still trying to be really good about hand washing and all of those things, mask wearing in high traffic areas. Late neurotoxicity, I think we've seen that in very small populations where we've seen a little bit of prolonged tremor, but thankfully it can be really resolving. But still, to have this in your differential as patients present with some of these late neurotoxic considerations. And then secondary malignancies, there's been a small subset of patients that we've seen some secondary malignancies in the T-cell lymphoma population, but we'll continue to evaluate. I think that's going to be something we'll see as we use these therapies longer and longer. So this is, I think, a really nice thing for patients to understand and for you to guide them through is when are we most concerned about some of these infections. And so when we're thinking about some of these more high-risk infections, fungal infections early on, where they're really reconstituting their immune system, and then there's the later long-term. And so this is where we think about long-term surveillance. These are patients that are still seeing us. We're still monitoring these components, but it can be in partnership with some of their other care teams. But for the first year is really when there is this varied immune reconstitution and where we're seeing some of these things start to resolve as we move through.
So I think we have some good questions here, but we have about 30 questions on our iPad. And I've tried to integrate and consolidate some of them in my head because I can't do it any otherwise. There's like no way that I can combine them. I had an interesting question pop up. I had a CAR T patient with neurosymptoms we treated with Dex. He ended up getting a lot of muscle issues and falling. He was an active man before. Besides starting physical therapy, is there anything else to prevent these symptoms after steroids? I would argue and be concerned that it wasn't this steroid-induced myopathy. It could be probably some of these Parkinsonian, ataxia, gait changes, the neurotoxicity from the CAR T-cell therapy. So in these patients, I send them to a neurology for consult. We'll do some EMG testing. Sometimes you have to do an LP, make sure they don't have any headaches or any other cognitive problems. And if it is just the steroid-induced myopathy, usually it takes a lot of dexamethasone over a long period of time to see that, especially in a fit person. So I would be really concerned that this, especially if it was like a cilta-cel compound, as we can see those, and it does resolve over time with a lot of work. Any other thoughts in the lymphoma groups?
Yeah, I agree. And then just general deconditioning, fatigue from the lymphodepleting therapy and the CAR T itself, people are just profoundly fatigued. It's hard for even active people to stay as active as they would like to be.
So we talked about long-term effects. What are some of the most common and complex symptoms patients experience a year after CAR T therapy? And we just saw that pretty slide that looked at the infections we worry about, the subsequent secondary malignancies. Usually it's very rare to get late neurologic effects, and so if they're having any of these, we want to make sure that we're getting them the appropriate specialist.
And I think some of the pieces too, when we think about late neurologic, because we think it's such a small incidence, is this unfortunately disease? If we're really concerned about some high risk, or if there was some consideration of leptomeningeal involvement or any CNS involvement, are we thinking that they have relapse in that consideration? So as effective as these therapies are, there's always an outlier of someone who's not going to be a great responder.
And then as for the subsequent malignancies, I really like, it's mostly the highest incidence are skin cancers, and so I like everybody to have a dermatologist, but there really are incidences of all sorts of solid tumors. And so after you get 6 months or a year out, people really should be seeing their primary care. They should be getting their PSAs checked. They should be seeing their GYN, getting their mammograms, getting their colonoscopies. A year out, they can get all these, routine health maintenance things. A lot of these folks have lived their life around their disease that they got their CAR T for, and then this is when they need to go back and really start doing health maintenance. And they really like to forget to do that because they feel like, we're doing that, and I assure them we are not.
I thought Amy was taking care of that.
We are not doing that. Those CTs are not picking up colon cancer. Those CTs are
picking up everything else.
Yeah.
So if you give Tosi, does it reverse the CAR? I think we had a discussion around that. We don't think there's preliminary data. We don't think that even though it's an anti-IL-6, it doesn't really affect the CAR T-cell expansion with the dexamethasone or Tosi. Are you seeing planned inpatient admissions that align up with suspected data on CRS or ICANS doses? So talk about lymphoma. So I mentioned our experiences. We usually don't see CRS or ICANS till day 7. We educate the patients. We see them regularly, but we admit on day 5 for a majority of patients. There are some patients that we just don't want to come in, and they live down the street, and we just see them daily. What's your experience?
Yeah, I would say that for the most part, depending on the product and depending on the type of lymphoma, that we can safely get away without any admission, and so we don't plan for it. I think, as always, there's always a potential, and so you have an urgent admission from clinic, but for the most part, in lymphoma, we're trying not to actually have anyone
Right.
scheduled as part of our ambulatory
Well,
program.
and it's very patient-specific, too. So if you have somebody with lots of cardiovascular issues, the 86-year-old, you know what I mean? You really are tailoring a lot of this to the patient, not only the patient, their comorbidities, but their support system as well.
Yeah, and we had a question about what the average grade of CRS is early on, and most of the time it's just a grade 1. Caitlin showed us some information about the CRS onset, and it varies with the product and the patient, but it tends to be grade 1, and if you jump in right then at grade 1, early on we waited until grade 2 to give Toci and Dex because we were afraid about turning off that cellular expansion, but now we know that it really doesn't affect it, and so right when they get that fever of 38 degrees, we're going to recommend a tocilizumab plus or minus dexamethasone. We do give a lot more liberal dexamethasone in myeloma than the lymphoma groups do, I think. We like dexamethasone short term, though, for myeloma, not long term. And so another question is, what would your first step for nursing education be when building a CAR T system? Like, let's say their hospital doesn't do CAR T. Hopefully there's people that do stem cell transplant. That's a cellular infusion. And it really is concerning to me that we have transplant centers that don't do CAR T at all. But what would your first step be for nursing education?
For CAR T.
If they wanted
Well,
to
I
build
would
a
ask
program?
you if you do bispecifics. That would be my first question, right? Because bispecifics are sort of CAR T light, because you need tocilizumab, you need a system to admit people if they're having, and in the lymphoma space, there are very few planned admissions now. In the myeloma world, I think there are probably more. But if you're doing bispecifics, then you have the framework to do CAR T. And then I would say if you're not doing bispecifics, I would recommend that you start with bispecifics and get your system set up
Get your
there
feet wet.
with your TOSI and your admissions and then move into CAR T, so to you know, sort of ease into it that way. That would be my recommendation.
Yeah, absolutely. And how close does the patient need to be to the hospital after infusion? And are there resources for patients that live in rural areas? And absolutely, we talked about all of the resources that the pharmaceutical companies that manufacture the products will give to the patients. They'll give them travel grants. My patients get a little credit card depending on their product, and they can charge the gas and all the incidental expenses, and then they'll cover some other expenses as well. Some programs have like $2,500, and it's really a nice benefit to the patient and their care partner. Anything else about how close, though, they have to be? So we want them to be within 30 minutes for our center. Some centers are 60 minutes.
Yeah, we're a 60-minute.
Yeah, we're up. I mean,
You're a 2-hour?
You can live in Australia and get a CAR T from the Dana-Farber.
yeah. No, I will say, but you know, this is the other thing. When you're in an urban center, 2
Yes.
hours could be 10 miles.
Yeah,
so
right, exactly.
Be cautious when you say 2 hours.
So it's very institution specific. So find an institution that lets you
Right,
live
but
at
then
home.
again, on the East Coast, I mean,
2
you're a
hours
little-
you could be in New York.
Right, and 2 hours from me,
You're
right,
in a
you
new
could
center.
be, you're going through Philly and you're almost in New York City.
Yeah.
So there's no reason. There's no reason
Exactly.
to have 2 hours, but you have more rural
Yeah.
referral.
So what about
base.
some weird adverse effects such as the Parkinsonianism and the immune effector cell colitis? So this is growing in popularity and awareness. In myeloma, we do see some immune effector cell colitis, but in my experience, even though we've done hundreds of CAR Ts, we don't see a high percentage. For some centers, they report, maybe 2% of patients will have a really bad colitis, that like diarrhea of 12 times a day and water and almost like a graft versus host type of diarrhea. We treat that with budesonide and corticosteroids in many cases, and we involve GI. Do you see a lot of immune effector cell colitis?
It is a rarity
I would
in
say
the
it's a
lymphoma
very
world.
rare entity.
I've seen maybe one.
And we see some of the Parkinsonianism, we think it might be linked to some cilta cell, although it has been reported in ida cell. But we have some studies that have looked at what we can do to minimize that. There was a paper that was reported out earlier this year that looked at the absolute lymphocyte count between days 7 and 14, and we observed, not we, me, but the immunotherapies group from the International Myeloma Working Group and Mayo Clinic, they observed that if there is a high ALC, that might translate to CAR T-cell expansion, and they gave patients dexamethasone. It turns out that not everybody is salvaged from that, but it's still in general, if you have a high ALC count within a short time after CAR T, we generally recommend dexamethasone to hopefully salvage some patients from not getting bad Parkinsonian symptoms. So
and that's,
it's very
and
institution
that's
dependent.
not something we see in lymphoma, the Parkinsonian. That's a myeloma.
That's why I'm here. I share myeloma pearls of knowledge. It's my job. How can we encourage our facility to transition to more CAR T-cell? There's a lot of burden on the provider, the staff, the nurses, right? So we have to see them daily in the outpatient when they're getting it outpatient. Sometimes it's easier to just admit them to the hospital. As you said, we don't like to admit lymphoma patients. We don't like to admit myeloma patients either. So if they have a good caregiver support, we will reserve a bed for them on day 5 in expectation of CRS onset of day 7, because 77% of patients, well, depending on the product, will get even a mild. But most people, hopefully, will not die from CRS. It's just, we got to stop that process. Qualifications for being treated outpatient versus inpatient for CAR T. Do you want to talk about who is not a good candidate for outpatient CAR T?
I think I mentioned that, like, extremely elderly people, somebody with not the greatest caregiver or no caregiver, if you're worried about some organ function, those are really the ones that are coming to my mind.
We have a small population too in terms of where we think socioeconomically where they're not going to be able to be reliable to come in and
adherence
back
to the supportive
and
medicines too.
kind of be in that time frame to self-monitor, to do the home blood pressures or things like that, where even though there's a low risk, we also just don't want to take that risk.
And then also, if they do have a caregiver, they might not be comfortable doing neurotoxicity monitoring, CRS monitoring. But there was also a question here, I'm integrating it now. Do you do ICANS checks every 8 hours or every 12 hours regularly? What's your institutional?
12.
I don't do inpatient.
I know you don't do inpatient, but what do those people
That's
do?
over by the time I see.
I think this is the piece when we think about ambulatory, there's a lot more infrastructure with our advanced practice clinicians on the daily rounding, but then also we have nurse navigators or our IAC nurses who are doing phone calls in combination with visits. So it does take a lot of infrastructure.
We used to do every 6 hours at the beginning back in the day of early days of CAR T, and now we just do every 12 hours because we're asking them to be aware of asking the patient if you have a headache, if you're feeling a little bit off and things don't feel as clear mentally, and the handwriting sample does impact. And I'm just intrigued that we had 2 separate questions on handwriting. So you are all very astute, and I've been doing this for a long time. I've never had that question. So thank you for asking it. Okay, this might be a loaded question. Let's see if it is. But how would you go about advocating for a CAR T program within a hospital system? I would love it if my hospital started up a CAR T program, especially since we take care of so many hematology patients. That's a great question. So talking to the penny pinchers is really important. Maybe you can quantify how many patients you've sent out to other institutions for CAR T. And if you have a practice that is really aggressive and referring out for transplant, referring out for CAR T, just look at how many of those were. And if it was like 10 in a calendar year, that's actually sufficient to support a CAR T-cell program. I was at a meeting in November, and this gal in North Carolina was she wanted to do that, and she advocated and was getting up and running a program in her area, and they had just done their first cell therapy, and she was so excited because she'd been wanting to do it for years. Nurses have a big voice, though, and so if you think that that's something that your hospital system can support, find out and quantify how many patients would be referred out would be my first thing. And I would look at all malignancies, not just the one that you might work with, lymphoma or leukemia, myeloma.
Right, and nurses really are the backbone of CAR T programs in terms of the education, the intake of patients, involved with the insurance clearance, educating the patient, the caregiver, all that monitoring.
And it's a big money maker.
The whole way through the, like, we couldn't do this without nurses at every layer of this, every step of the way.
Absolutely.
If a patient is reacting to the CAR T and they're having the CRS, is it better to start the steroids first and use Toci as a last resort? That's a great question. If they're outpatient, we give them what we call pocket dexamethasone. So we give them dexamethasone to keep in their pocket in case they develop a fever. So if they are outpatient, then absolutely we give them dexamethasone, and we give them instructions for how to seek care. There are centers across the country, Mayo Clinic, Emory, that have a infrastructure with a 24-hour, 7 days a week urgent care for the patients, and we don't have that in Cleveland. I don't know that you have that in your center, but that would be something too. Should we go to I think we only have just some of these questions on here that are in, there's the survival rates for patients who did not experience ICANN or CRS are the same. We talked about repeating the CAR for a target, and the answer is yes, especially if they received Abecma and myeloma. It tends to have a shorter survival, 11 months, versus cilta-cel, which is 22 months in the heavily pretreated patients. And so we think that just repeating it after time has elapsed can be done, but there's other drugs to consider as well. Okay, we're going to just go through here. There's a concluding remarks. Let's do 2 more questions, then we'll do concluding remarks. Okay, we had a discussion about sub-Q IG and IVIG. Talk about how you give IVIG supportive care in your areas.
I am a huge advocate for subcutaneous IgG. Our immunology team is very vocal that when you give intravenous immunoglobulin, the level spikes, and by the time the next infusion's due, it's gone. Right, but if you do subcutaneous, and Hizentra is the most common one, but there are others, and patients do it weekly at home. They self-inject, and then their level stays much more even. There aren't those peaks and valleys, and these folks are really at high risk for infection. So to have them covered for 2 or 3 weeks, and then they have a week where they're a blank slate again. Doesn't make a whole lot of sense. Now, in Beth's population, where they're only getting it for 6 months, it probably doesn't make sense to hook them up with Hizentra at home. But in the lymphoma population, we have people who are on this forever.
And we do too, for we have the functional and absolute hypogammaglobulinemia from the disease and treatment. So we do have people that get it regularly, but we try to just tailor it to the patient.
But it's also, then they're in the infusion chair, right? They're coming in, it's a special trip. We all have way more people than we can accommodate. Our infusion chair space is getting tighter and tighter and tighter everywhere.
For patients that have prolonged cytopenias, do you do anything besides growth factors? I'll do platelet growth factors for some of our patients. We'll do a white cell growth factor for patients, ESAs for patients, for blood if they're anemic. But I would really be worried about what's going on in the bone marrow production plant. If you have prolonged cytopenias after 6 months, these patients are at risk for secondary cancers, including myelodysplastic syndrome and leukemia. We're now identifying a population of patients that have what's called CHIP changes, the clonal hematopoiesis of indeterminate potential. There's also a category called CCUS, clonal unknown significance. It's like an MGUS for leukemia. And so making sure that the bone marrow is still healthy and it's not filled with cancer cells, or it's making itself as the way it should be. Some people will give stem cell boosts if they have stem cells laying around, but we haven't had to do that in most of our patients. But anyhow, I think we've had such a rich discussion, and we have 3 minutes left, and I don't see anything on this slide that we haven't really addressed other than the HIV positive patients receiving CAR therapy. I have not had any experience with needing to give any of your lymphoma patients.
No, but there are clinical trials that are currently activated. I know that there's a couple of centers that I'm familiar with that have these enrolling.
Yeah, because they tend to have different side effects. Their toxicities can be very different, especially the heme malignancies. Not so much in the solid tumor world, but in heme malignancies, the HIV population, it's typically the heme malignancy comes from immunodeficiency, whereas in the solid tumor world, they're typically not immunodeficient. They just developed whatever malignancy they would have developed had they not had their HIV. So it is a different population in the heme space.
Absolutely. Well, thank you so much for joining us today. Thank you to Medscape Oncology for putting through this program, and all of our wonderful supporters. We want you to earn your credit, so please click on the Earn Credit icon scanning the code. So before was join, and now this is a credit code. And this is only valid through June 12th, 2026. So we urge you to just do it now. Get it over with. Get your credit. You sat here and listened to us for the last hour and a half. You might as well. Thank you so much. Enjoy the rest of your conference.
Thank you.
Take care.